All right, very warm welcome to all the attendees. Very warm welcome to the panelists and all the IT team, steering committee team for another great session of Global Academic Radiology Education Program. So this would be our first musculoskeletal session, one of the 4 musculoskeletal webinars what we're going to be doing. I'm Dr. Panathapura, JP. I'm one of the cardiothoracic radiologists at Wake Forest University. So just very brief introduction of what AREP is. So Academic Radiology Education Program is a nonprofit initiative which is aimed at providing high-quality radiology education to all the radiology colleagues worldwide. We started this in 2021, and it's based at the Department of Radiology at Wake Forest University School of Medicine. And it offers free online education resource and live webinars featuring academic radiologists from leading US institutes. Again, the program is designed to bridge education gaps, particularly for radiologists in resource-limited settings, by sharing expertise and fostering global collaboration. So we host bi-monthly webinars from Jan to October, which is covering various radiology subspecialties. It is very well attended with nearly 700 participants per live event. And we have contributions from esteemed institutes, and we reach out to radiologists in different countries in Asia, Africa, and Middle East. And this program's success is driven by the dedication of its committees, moderators, and speakers who work tirelessly without external funding. In addition to webinar, AREP offers projects like Radiology Excellency Program, which focus on mentoring and specialized radiology challenges in various countries. So today we have a MSK talk on imaging of inflammatory arthropathies, and our moderator is Dr. Buriad, and Dr. Buriad is a senior radiologist from Intermed Hospital from Mongolia. So over to you, Dr. Buriad.
Okay, hello everybody, and welcome to ASR's educational webinar series. My name is Ananchima Buriat, and I'm very pleased to welcome those who are joining us for the very first time. And if you're rejoining us, thanks again. And so we have a wonderful session for you today on imaging of inflammatory arthropathies, which will be presented by Professor Mahatarabi. And we hope this session will provide you with some new insights and some learning, and also practical information that can be applied in the context of your work. So also we encourage you to ask questions throughout the Professor Torabi's lecture by simply entering the question in chat box, and we will answer those questions at the conclusion of the session. So I'm very pleased to introduce our today's special guest speaker, Dr. Mahatarabi. Dr. Torabi holds an MBBS from Tehran University of Medical Sciences, earned in 2000. She completed her residency in medicine at the University of Nevada in 2003, and furthered her training at Massachusetts General Hospital in 2004. Dr. Mahatarabi specialized in radiology at Brain Mar Hospital in 2005 and pursued advanced education in radiology at the University of Pittsburgh Medical Center. Following her education, Dr. Torabi completed a fellowship in musculoskeletal radiology at the University of Pittsburgh Medical Center in 2009. She's an American board certified radiologist with special competence in nuclear medicine. And currently, Dr. Torabi serves as an associate professor of radiology at the University the Wake Forest University, where she contributes her expertise to the department and its affiliates while she actively engages in research activities. So I hope you guys enjoy tonight's lecture as much as I would, and I find it interesting and both provoking. So without further ado, I would pass control over to Professor Mahatorabi, and that's all yours, Dr. Torabi.
Thank you, Dr. Buriat, for the introduction. It's an honor to be here. In the next hour or so, I'll be talking about imaging of inflammatory arthropathies. I would like to save some interesting cases we see, usually traumatic, to keep my residents awake. So if you have any such cases to share with me, I appreciate them, such as this pitchfork injury or this like luxatio superior dislocation of the hip joint. And if you wonder how did that happen, it was a tubing accident like this. Okay, I do like unusual foreign bodies such as this that happened in this rollover motor vehicle accident. But to get to our talk, we're going to talk about processes that involve the joint. The most common pathology of the joint we see is osteoarthritis, especially in the aging population. But the differential of pathologies that love to involve the joint are inflammatory disorders, septic arthritis that I won't get to for the sake of time today, crystal arthropathies that I would touch briefly on, and some miscellaneous diseases like PVNS and osteochondromatosis. So starting with, my goal is throughout this to show you cross-sectional imaging of these arthropathies, and these help you with pattern of disease, detecting early imaging findings, and with all these, they make you appreciate these pathologies on plain film radiographs better. So why do we do cross-sectional imaging, mostly ultrasound and MRI? Whereas, you know, most around the world, X-ray is the primary tool of imaging. Now, with more remote radiology, as is happening here, sometimes X-rays are not available and you only have the MR imaging to look at. In addition, MRI and ultrasound both are more sensitive to detect early changes of disease, and they can be used to track response to treatment with the new drugs research studies. So when you look at the joints, such as this knee joint, and you see synovitis, which is shown with this arrow as this kind of gray proliferation of the synovium, you can suspect some synovial and joint pathology is happening, but synovitis, as we'll see throughout this talk, is not specific to any disease. The patients need a lot of lab work, and you have to look at the distribution of disease to come to a diagnosis. So starting with inflammatory disorders, you know that there's a lot of them, and there, in addition to those, they kind of overlap, and there is mixed connective tissue disease. But for imaging, you can easily divide them into seropositive arthropathies and seronegative inflammatory arthropathies. The seropositive ones are rheumatoid arthritis and lupus, and the seronegative ones are considered ankylosing spondylitis, psoriasis, and Reiter's disease. And on these ones, based on distribution of disease and pattern of involvement, kind of you can help diagnose the pathology in these patients. So we're going to start with seropositive inflammatory arthropathies, mostly rheumatoid arthritis. So when you look at the joint, this is a normal joint. You can see the bones. You can see the synovium covering the joint. This is the capsule, and these are the extra articular structures. So what happens with rheumatoid arthritis or seropositive arthropathies is that the synovium gets inflamed. It gets inflamed and it gets hypertrophied. And this is the hypertrophied synovium that we call pannus. This pannus is going to cause first marginal zone marrow edema and then erosion. And the reason it causes marginal zone edema and erosion is that that's where the articular cartilage is thin, and articular cartilage is kind of protective against erosion. And therefore, that kind of marginal erosion, when you say you're implying an intra-articular pathology and you're implying something infectious or inflammatory. With time, more erosion and destruction happens, and then the patients get secondary osteoarthritis. When you look at seronegative arthropathies, they have the same synovial pathology. So they get synovial hypertrophy, they do get marginal zone edema and erosion, but they are both erosive and proliferative. So in addition to erosion, they start getting some whiskering periostitis, and with time, they can even develop ankylosis due to extra bone formation. And when you look at crystal arthropathies such as gout, what happens is that the extra crystals in the blood deposit anywhere, and they can deposit in or outside of the joint. And these deposits can cause what we call juxta-articular erosion. So if you use the word juxta-articular, you're implying something happening out of the joint. And if there's an ulcer, that's either osteomyelitis, or if there's no ulcer, you're just implying gout if you say juxta-articular erosion. All right, so starting with rheumatoid arthritis, more common in female, age 20 to 40s. The problem is inflammation of the synovium that we call pannus. Where do we have synovium? We have them in the joint, in the bursa, and in the tendon sheath. This pannus is isointense on T1 and T2, and it would have intense enhancement. Since we're going to be talking a lot about synovium, I'm showing you the histopathology of the synovium. If you look at it normally, it's 1 or 2 layers of cells, a few kind of fat cells, fibroblasts, and blood vessels like this. What happens with synovitis is that it becomes, those 2 layers become multi-layered. They start getting some giant cells. The blood vessels get engorged, so they get more blood vessels and more inflammatory cells. And that's why when you look, these are multiple arthroscopic images. Anything that you see red is synovitis. Here you see synovial proliferation. You can see increased vascularity and inflammation as red tissue that the surgeons see arthroscopically. This is a histopathology specimen and an MRI examination to show you that marginal erosion. You can see this is the articular cartilage, this is the bone, this is where articular cartilage is thin, so the bone is susceptible to erosion, and you can see this proliferative pannus eroding into this marginal zone, and this is kind of the MR equivalent. This is a case of septic arthritis with marginal erosion. All right. So now I'm going to show you a few examples of rheumatoid arthritis involving different joints. So in the wrist joint, the distal ulna, especially here adjacent to the styloid process, is where the kind of marginal zone sort of is, because that's where the articular cartilage gets thin. You can see this erosion on plain film radiograph. You can see equivalent of it erosion on T2 and T1 weighted images. And so, you know, for research purposes, the definition of erosion is loss of cortex. So you can see this cortex is gone, and you can see this inflammatory pannus into the erosion and in distending the distal radial ulnar joint. This is the same MR image. This patient actually was not prospectively diagnosed as having rheumatoid arthritis. They thought it's a triangular fibrocartilage pathology. So the surgeons went into, and when they go through radiocarpal joint. And you can see the radiocarpal joint is actually not affected. And they looked at the triangular cartilage. They put some sutures in it to fix it peripherally to the styloid process. And you can see how this whole pathology deep to the triangular cartilage was missed arthroscopically. This is the shoulder X-ray on the same patient. You can see this is a normal glenohumeral joint. This is the humeral head. This is where the marginal zone area would be in the humeral head. That's where the cartilage gets thin. You can see this erosion on plain film radiograph, and this is MR proton density and T2 equivalent sequences. You can see this erosion, adjacent marginal zone marrow edema, and you can see this distension of the glenohumeral joint with this pannus and synovitis. In the hand, rheumatoid arthritis likes to involve distal radio-ulnar joint, radiocarpal joint, midcarpal, carpometacarpal, MCP and PIP joints, basically from here down. To show you some examples, this distribution helps you on plain film radiograph to suggest rheumatoid arthritis. In the knee, this is an example of juvenile rheumatoid arthritis. You can see this marginal zone marrow edema that can develop into erosion, and you can see associated effusion and synovitis here along the medial and lateral joint line. Here on the axial images, you better can see there's even distension of the Baker cyst with this synovitis. So this is an MR equivalent of the X-ray we saw. You can see extensive erosion of the distal ulna, the carpal bones. And then with time, these pannus and erosions cause a structural damage and destruction. So here there's tear of the triangular fibrocartilage. So there's secondary osteoarthritis, the fixed deformities that the patients develop, and superimposed osteoarthritis. This is another example of the patient with wrist pain. You can see there's synovitis of the distal radio-ulnar joint, and you can see there's also tenosynovitis because RA, in addition to the joint, likes the bursa and likes the tendon sheath. So once you see synovitis in multiple compartments, you suspect a more systemic process, such as this. This is involvement of the radiocarpal joint with extensive effusion and synovitis. This is a patient that presented with only tenosynovitis. You can see this distension of the ulnar bursa here in volar aspect of the wrist, and also the extensor tendon compartments, multi-compartmental tenosynovitis related to rheumatoid arthritis. In the foot and ankle, like similar to hand, rheumatoid arthritis likes the tibio-talar joint, midfoot, and MTP joints. This is rheumatoid arthritis involving the tibio-talar joint. You'll hear me repeat myself over and over again. Joint effusion, synovitis, marrow edema. And once you see the pattern of disease, the chronicity, they don't have infection symptoms. There is usually pathology symmetric bilateral. You suspect inflammatory arthropathy. These are the post-contrast images on the same patient. You can see the extensive synovitis of the tibio-talar joint and a little bit of flexor tenosynovitis. This is another patient presenting just with tenosynovitis in the ankle joint related to rheumatoid arthritis. You know that on plain film radiograph, the MTP joints, particularly the starting laterally at the fifth MTP, is where rheumatoid arthritis likes to manifest itself. And you can see on MR equivalent of it, this is effusion synovitis, marginal zone erosions of the fifth MTP joint, but there's also involvement of the midfoot and Lisfranc joint. And that's another area rheumatoid arthritis likes to involve. So this is the early rheumatoid arthritis of the glenohumeral joint I showed you. And if it progresses with time, you can see this case of advanced rheumatoid arthritis, where now there is rotator cuff tear, and this glenohumeral joint effusion and synovitis has decompressed into this subacromial subdeltoid bursa. And you can see this marked proliferation of the pannus in the bursa. In the elbow joint, it's not any different. You see distension of the capsule with this effusion, with this pannus and synovitis. You can see erosions, especially in the elbow. The supracondylar region is the first area to show erosion and marrow edema here. And subsequently, there's cartilage loss and joint damage and severe osteoarthritis superimposed. This is a nice case of bilateral symmetric involvement of the hip joints in the patient with rheumatoid arthritis. You can see the so-called apple coring of the femoral necks, distension of the joint with synovitis. And this is how it looked arthroscopically when the patient underwent synovectomy. Now, patients with rheumatoid arthritis can develop rheumatoid nodules at the sites of friction, which is kind of like bursitis, adventitial bursitis. It's usually low on T1, variable on T2, and it shows enhancement like this case, as you see on T1 and T2 weighted images in the heel fat pad. So moving on to seronegative arthropathies, they usually involve one joint. The difference between seronegative and seropositives are the seronegatives like the joints, but they also like the ligaments. They like the sacroiliac joints and the spine, where there's plenty of ligaments. And in the hand and feet, they usually involve the DIP and sometimes the PIP joints. Starting with Reiter's disease, usually it happens with some infectious process such as GI or GU infection and conjunctivitis. This is honestly, I haven't seen that many cases of Reiter's. This is the only confirmed one I have, that the patient had GU infection and developed this enthesitis. You can see at the origin of the gluteus maximus from posterior iliac tuberosity, and here anteriorly at the anterior superior iliac spine, origin of iliotibial tract, there is this inflammation. And I kind of really appreciate post-contrast images because it really shows where the inflammation and enhancement is, as you can see in this case. Psoriasis likes to involve the DIP joints of the hand and feet, the sacroiliac joints and the spine. You know the soft tissue swelling, the so-called sausage digits, and it does cause marginal erosions, but at the same time it's proliferative, so it can cause some periostitis and the so-called whiskering osteophytosis. With time, they can develop this destruction and so-called telescoping or arthritis mutilins, that where you can see the digits like telescoping to each other, and then they could also ankylose and fuse. The good thing is most of these patients, once they have articular disease, they also have a skin involvement. So if you see them for ultrasound, the skin involvement helps you diagnose the joint pathology. This is a case of soft tissue swelling, the so-called sausage digit. And like, again, rheumatoid arthritis, the process starts with marginal zone marrow edema, erosion, but then they can develop a sclerosis and fusion. So this was a patient, came with long finger PIP joint swelling. You can see this marginal zone erosions. And this is a great case of seeing how this whiskering periostitis so-called is. So when you have monoarticular process, the first thing you have to exclude is septic arthritis. So this patient did get an MRI, and on T1, T2, and post-contrast images, you can see this distension of the capsule and synovitis with some marrow edema. And you can also these erosions that you better saw on plain film radiographs. And we had to put a needle into this joint to exclude septic arthritis, and later the patient was diagnosed with psoriasis. This is kind of similar process, as you can see, involving IP joint of the great toe. On plain film, you can see marginal zone erosion. You see the periostitis. And on MR, again, you see the marrow changes, distension of the capsule with effusion and synovitis in a patient with psoriasis. This is advanced psoriasis involving the tibio-talar joint. Again, effusion, synovitis, and large erosions of the talar dome. This is the sagittal equivalent, showing you the same process, the effusion, synovitis, marrow edema of the talus, and large erosions. And this is the knee on the same patient. And you can see effusion, synovitis, and you can see the inflammatory process is kind of like insertion of the popliteus tendon, this large erosion at the insertion of popliteus tendon. And I believe I have axial images too, so you can appreciate how thickened this synovium is here, mostly synovitis. The seronegatives also like the enthesis, as you saw in that case of Reiter's disease. This is a patient with posterior ankle pain. You can see how with time from 2011 to 2012, they're developing what we call subenthesial erosion deep to insertion of Achilles tendon. And with time, see, in addition to erosion, they get proliferative changes and periostitis and extra bone formation, which doesn't happen with rheumatoid arthritis. So that erosion is equivalent to this MRI. You can see deep to entasis of the Achilles tendon. There is what we retrocalcaneal bursitis. You can see this inflammation around in the region of retrocalcaneal and retroachilles bursa. You can see this marrow edema of the calcaneus, which developed into erosion and subsequent healing with extra bone formation. All right, giving you a breather, wear your helmets. And this was a case from ACR, College of Radiology. It's a 90-year-old patient. They put her on the scanner, and actually she had passed by the time they imaged, so you can see the hematocrit level in the heart. So not a thing you see every day. Okay, moving on to ankylosing spondylitis. So what happens in the spine is that they get the squaring of the vertebral bodies, they get the same marginal zone or where the ligaments attach, they get erosions, and those erosions heal with the sclerosis that are called shiny corners, and then they make extra bone, which is called syndesmophytes, and that results in bone effusion and ankylosis. They are osteopenic and they have this fused bone block, so they're very susceptible to spine fractures. Again, ankylosing spondylitis, the pathology is in the synovium and also in the ligaments. So involvement is strong around the sacroiliac joints and around the spine, where there's a lot of ligaments. In the sacroiliac joint, when you look at inflammatory sacroiliitis, if it's bilateral and symmetric, you think of ankylosing spondylitis and IBD. If it's unilateral, you think of psoriasis and Reiter's disease. In the large joints, like ankylosing spondylitis, like hips and shoulders, the large joints, you can get similar effusion synovitis. Supposedly in hips, you get axial migration. So instead of superior joint space narrowing, you get axial joint space narrowing. I personally haven't found that very useful in my experience. This is the ankylosis that you see at the here at the costotransverse ligaments and costovertebral ligaments. You see these ligaments are all ossified. Here there is ossification of the interspinous ligament, ossification of ligamentum flavum, and syndesmophyte formation. So you can see all these ossification of the ligaments on CT. This is a 53-year-old patient with shoulder pain and ankylosing spondylitis, and you can see this is inflammatory involvement of the shoulder joint with effusion, synovitis, and some marrow edema. So the process is inflammatory. This is a patient who came to emergency room with left hip pain, and you can see on x-ray there is asymmetric periarticular osteopenia around the left hip joint. The patient had left hip pain and they were suspicious of septic arthritis. Now, if you look, actually, there is some irregularity of both sacroiliac joints radiographically. You definitely appreciate the subchondral sclerosis, and maybe I can talk you into there is some associated erosions as well. Anyhow, the patient underwent an MRI examination that you can see on T2 and T1 post-contrast images. There is hip joint effusion, synovitis, and marrow edema. There's not much periarticular inflammation that you see on septic arthritis. In addition, you can see there's bilateral sacroiliitis. So if you have monoarticular pathology, you have to exclude septic arthritis. Once you get polyarticular pathology, then you start thinking, oh, maybe it's a systemic process. And in this patient, actually, this was done after hours, and one of our residents put the preliminary report in, and he suspected inflammatory arthropathy given sacroiliitis and polyarticular involvement. The patient unfortunately left without further follow-up from ED, but came back 1 year later, and you can see now there is superimposed moderate, at least, degenerative changes of the left hip. Now, if this was septic arthritis, this hip joint would be destroyed. So that kind of a slow progression clues you more into the fact that this is inflammatory. And now you can appreciate progression of the sacroiliitis as well with erosions and sclerosis. So this is a case of unilateral sacroiliitis in a patient with psoriasis. Again, if the process is bilateral, you suspect ankylosing spondylitis and IBD. If it's unilateral, you suspect psoriasis and Reiter's disease. Showing you more spinal changes of ankylosing spondylitis. As we spoke, again, in the spine, you get ossification of the facet joints, costotransverse and costovertebral joints. I'll show you the Romanus lesion and Anderson lesion. So you're all familiar with this advanced kind of bamboo vertebral body that all this syndesmophyte formation anteriorly, fusion of all the ligaments. This is the equivalent MRI on T1 and T2 weighted images. Here is where you have a squaring of the vertebral bodies. But before this happens, they get end plate erosions, which is called Romanus lesion. They initially get end plate erosion at the insertion of the syndesmophytes, and then these erosions heal with a sclerosis, and these are called Romanus lesions as well. So they heal with this shiny corners, and then this is the MRI equivalent. And when they have the erosions and then they develop a sclerosis, you can see this kind of corner marrow edema at the insertion of the syndesmophytes. And then with time, they just fuse. Anderson lesion is inflammation of the disc, which is inflammatory and not septic. And by imaging, we cannot distinguish this from septic arthritis. It is not that common, but this was one of the cases that the patient had ankylosing spondylitis, had this fluid in the disc. We had to aspirate it to exclude septic arthritis. And this was an example of Anderson lesion, which is discitis, inflammatory changes of the intervertebral disc. When they heal with fatty marrow changes and some fusion across this space. And this is another example of Anderson lesion with fluid signal mimicking septic discitis and osteomyelitis in the spine. Again, these people have fused vertebral bodies, and that makes them susceptible to fracture. So each time they come through emergency room after trauma, be very careful to look for these subtle fractures. And because they're osteopenic, they can be very hard to detect. So we looked at all these synovial processes, and I said a zillion times probably effusion, synovitis, marginal marrow edema. The thing is, the synovial proliferation is very non-specific. It has a wide differential diagnosis. So you have to put it in clinical picture, look at the labs, tap the joints to exclude infection. And then your differentials are inflammatory arthropathies. But at the same time, post-operative synovitis or joint hemorrhage in setting of trauma could also mimic inflammatory arthropathies, that I will show you. And then there's some cases of non-inflammatory synovial proliferation, as you know, like synovial osteochondromatosis and PVNS. So going to those non-inflammatory ones, PVNS, you know, is young patients, usually single joints. It has intra-articular and extra-articular types. The classic feature is that it's low on T2, and on gradient echo sequence, it blooms because it has hemosiderin in it. This is a case that we can see distension of the tibiotalar joint with this low signal intensity mass. And this is kind of the low signal intensity is kind of crucial for diagnosing PVNS. This is a patient, came for hip arthrogram. You can see this feeling defect in retrospect in the joint that correlate with this low signal intensity on T1 and T2 weighted images. And on arthroscopic excision of PVNS, you can see this hemorrhagic nodular masses in the joint, hip joint recess. Synovial osteochondromatosis is also synovial proliferative disease. It usually involves single joints. It can be related to secondary to osteoarthritis with multiple joint bodies. If the joint bodies are calcified, you see them on X-ray. If they're cartilaginous, you see them better on MRI. This is an example of, because I showed you hip, this is multiple joint bodies within the hip joint. This is how these multiple chondral bodies look like at the time of removal. And this is a case of synovial osteochondromatosis involving the distal radial ulnar joint. Another one, they can cause apple coring. Look at that beautiful erosion of the femoral neck due to pressure in the hip joint. And this is a case of post-op synovitis. This patient had recent arthroscopic surgery. The knee joint aspiration, it didn't look infected, but you can see how much synovitis and inflammation there is. And this was supposed to be post-op synovitis. I do have time for crystal arthropathies, and we're going to discuss gout, CPPD, hydroxyapatite deposition disease. So gout, is extra uric acid crystals that there's extra of them, too much of them in the blood. What happens is that they go to extremities where temperature is cold and they decrystallize. When they decrystallize, they can deposit in or out of the joint. And once they deposit, they cause some granulomatous reaction around them. And that kind of creates this tophus that you see on imaging. Again, on plain film radiographs, they are easily diagnosed. You can see this hyperdense mass. The point is that the masses are hyperdense, but they rarely calcify. This is an example of extra-articular erosion. This is articular erosion. And this overhanging edge or the rat bite erosion are the buzzwords you use for this erosions related to gout. So these tophi are usually low to intermediate on T1 and T2. And because there's some inflammatory cells and inflammation around this tophi, they do have mild enhancement. We have had this sometimes on the big toe called infection on MRI, but you have to, the main distinguishing feature is if there's no overlying ulcer, infection is very unlikely in this patient. So if there's no ulcer and they have inflammation, I put inflammatory arthropathy such as gout or crystal arthropathy such as gout top on the list. Okay, so gout can deposit anywhere the temperature is cold. Usually they are dense but not calcified, and they can also deposit in the tendons. So just to repeat this to you, this is an extra-articular erosion. This is juxta-articular out of the joint. So once you say it, basically, you cannot say rheumatoid arthritis. I had this case like early on in my career, the patient without plain film radiographs. And you can see this kind of nicely on T1 weighted, and this is T2 weighted images, these rat bite erosions and overhanging edges. These are articular erosions in the first MTP joint. You can see also overlying that tophus with hallux valgus here, there is this bursitis. So we can see the bursitis separate from the tophus with associated erosions. And these are the post-contrast images. You can see the bursitis is not enhancing, but all those inflammatory tophus and marrow edema related to tophus is enhancing. And you can see there's also some involvement at the fifth MTP joint. Again, first and fifth, because they're at the periphery and colder, are more susceptible to involvement. Now, tophi usually don't calcify around the joints, but they do calcify in the bursa. So this is the case of olecranon bursitis. You can see calcification associated with the tophus, and you can see it's symmetric bilateral. And that's the thing. Once you suspect inflammatory arthropathy, just go open up and pull up any other joint you can have on that patient. Usually I pull up the abdominal CT to look at the sacroiliac joints. I look at the feet x-rays, and I look elsewhere to see if this is a systemic process or is it a monoarticular process, whatever I'm looking at. This is a case of prepatellar calcific bursitis related to gout. This is a patient, like you can see on the knee radiograph, there's this lumpy, bumpy, hyperdense mass along the medial joint line. You'll see that that's the origin of the medial collateral ligament. And also here at the projecting over where the popliteus tendon would be in the lateral joint line. And here you can see hyperdense mass at the attachment of medial patellofemoral ligament, MPFL, and correlating with that on the MRI. And I usually like T1 weighted image because you can see the distension along lateral joint line with displacement of this lateral ligament structure due to this tophus deposit, which is depositing on the popliteus tendon, causing erosion at the insertion of popliteus tendon. And also you can see tophus deposit at the origin of MCL and here at the MPFL. So this is gout involving the knee joint. Sometimes they come in through the ED, which is joint effusion. If they tap the joint, of course, they see the crystals. Here, if you look at the CT examination that was done for other reason, you can see this deposit and erosion at the insertion of popliteus tendon. Gout particularly likes popliteus tendon. So if you see any deposit on popliteus tendon, that's most likely gout. Just to show you an example, this is, again, you can see this hyperdense tophus along medial joint line. This patient actually, interestingly, went for tophusectomy arthroscopically, and that's how I got these images of how tophusectomy looks like. This is another example for you to see how it deposits in the tendon. This is involvement of the, if you see inflammation around the knee, you see involvement of the popliteus tendon, then you know that this is tophus depositing in the patellar tendon. All right. This was an interesting case. A patient with, I believe, ALL had knee pain, and they were suspicious of septic arthritis. So the patient was sent, the tap at the floor was kind of unsuccessful. So they sent it to ultrasound or ultrasound-guided knee aspiration. And you can see on X-ray there's not much fluid. And there's minimal, you can see mineralization here or hyperdensity where the popliteus tendon is. And on ultrasound, really, there was a small amount of fluid, but it did not look inflamed. But when I looked at around the medial collateral ligament on the unaffected side compared to affected side, you can see, and what you do is that you have to choose the color setting and don't change it from side to side. You can see when you go from the unaffected side to the affected side, there's extensive inflammation and hyperemia around the MCL, and same laterally. This is the affected side and this is the unaffected side. You can see there's extreme there was actually, the skin was thickened, so it was swollen, the knee looked warm, but there's this hyperemia along medial and lateral joint line. And the patient, when I asked, had diagnosis of gout. So this was a gout flare in the knee joint and not septic arthritis based on distribution. And that's, I believe, the tophus that we saw on the plain film radiograph. And this is a patient came with olecranon bursitis. You can see this kind of inflammatory mass with hyperemia in the region of olecranon bursa, and these numerous hyperdense tophi, the mineral deposits that you can see on ultrasound. And again, he had history of gout. So sometimes they present to our department and we don't have a diagnosis, but once you start talking to them, they confess to the diagnosis. Now, this is a very unusual case. This was a patient that was referred to us for septic arthritis of the facet joint to aspirate. And you can see there's all this inflammation around the facet joints. But when you look, it's very odd. You can see how on CT, there's this hyperdense masses around the facet joints. And this guy might have some genetic problem because he had tophus deposits even like centrally, where usually gout doesn't deposit because the temperature is high. He had all these tophi around the spine. He had that here is we biopsied and we got white chunk of tissue out. And he had this tophi depositing in his hip joints. And this is like extensive tophi descending the ankle joints, great toe. And it was sad. You can see this is ulcerating here because of all this. I haven't seen, this is just the extreme case of gout. And he ended up passing from sepsis because of all this ulcerating tophi resulting in infection. Moving on to calcium pyrophosphate disease, or CPPD, you know it likes to deposit on hyaline cartilage, which is articular cartilage, or fiber cartilage, which is CPPD. It can deposit on the capsules, on the ligaments, on the tendons. You've seen them at the origin of the hamstrings or gastrocnemius. They can have variable signal, but usually low signal intensity. They can present with inflammation that looks like gout, but it's in fact pseudogout, or they can present with what we call CPPD arthropathy, which is osteoarthritis in atypical osteoarthritis distribution. And again, the diagnosis for majority of these inflammatory and crystal pathologies are in aspirating the joint, looking for crystals, and doing lab work, looking for markers. So this is a patient with chondrocalcinosis. There's also some ulnar positive variants probably, and some ulnocarpal impaction syndrome. But to show you the associated MR images, usually it results in what we call non-specific cystic changes of the carpal bones. You can sometimes, and this is the synovitis that goes with either secondary CPPD arthropathy or related to pseudogout. Sometimes, like this case, you can see low signal intensity correlating with CPPD deposits. And this is just, again, if you suspect it, go look elsewhere. If it's subtle, you're like, okay, let's go look at the symphysis pubis, look at the hip joints, look elsewhere, see if there's more chondrocalcinosis to confirm your diagnosis. And I usually don't say where it is, because usually it's systematic. And there's a lot of joints that are involved. So if I see them, I just say chondrocalcinosis. I don't say where. This is a lady that was moving books in her bookshelf, and she felt a crack, had multiple x-rays. She didn't have any fracture, but you can see she has this kind of soft tissue swelling on x-ray, and she has chondrocalcinosis. And on ultrasound, she had this inflammatory mass in volar aspect of the wrist. She didn't have infection, and I suspect this is just these crystals, when they released, they cause a lot of inflammation. And I suspect this is a case of pseudogout related to that inflammatory process. Again, they can be bright or dark, and that is challenging when you have deposits in menisci and they happen to be bright. Then you don't know if this is meniscal tear or CPPD deposits. So kind of, if you describe the signal here, you have to give a caveat that it could be tear, it could be CPPD. And this is a case of CPPD arthropathy that with chondrocalcinosis, high-grade patellofemoral degenerative changes, or chondrosis, like in this case, is one pattern of CPPD arthropathy. In the wrist, you know, it can cause a slack wrist and hook osteophytes in the second and third metacarpal heads. This is just a plain film correlate showing you chondrocalcinosis and patellofemoral osteoarthritis. HADD, or hydroxyapatite deposition disease, is you're familiar with it around the shoulder joint involving the rotator cuff. It kind of gets a bit tricky when it deposits elsewhere and causes inflammation. So I'm going to show you an example of elbow and wrist. I really like this picture that shows different phases of hydroxyapatite deposition. When it deposits, you know, that's just chalk-like calcification you see on plain film radiograph. It can be silent. If it's small, it can be absolutely asymptomatic. But if it's large and big, just based on size without any inflammation, it can cause impingement symptoms. But it can get released into the overlying bursa or released into the underlying bone and causes a lot of inflammation. And that is called calcific bursitis or calcific osteitis. And with time, the body just absorbs it. You can see like it gets smaller, and then disappears. So this is kind of the different phases of hydroxyapatite deposition. As you can see, it can be misdiagnosed, especially if it's an atypical distribution. So this is what you're familiar with. This is a large calcific tendinitis in supraspinatus tendons. So just based on size, this can cause pain and impingement. Now, this is the one that has burst into the overlying bursa and embed to the underlying bone. So it's resulting in calcific bursitis and calcific osteitis. And we can, with ultrasound, put a needle in them and aspirate as much as we can. Like in this case, we aspirated it all and it went away. But because they're very inflammatory, and when you aspirate them, some of them get released, at the end, you have to make sure you put your needle back into the subacromial subdeltoid bursa, or if it's elsewhere in the overlying bursa, and inject corticosteroid to reduce that inflammation. This is a case of a patient that came with ultrasound correlate showing you subdeltoid bursitis related to hydroxyapatite. This is the patient that came with elbow pain. You can see how this can simulate infection. There is extensive subcutaneous edema, marrow edema. So you can suspect, is this a case of olecranon bursitis and maybe osteomyelitis? But you can see there is this low signal intensity focus in the distal triceps tendon that you can see here on axial T1 and T2 weighted images, and extensive adjacent inflammation. And when you correlate radiographically, you see this large deposit of hydroxyapatite in the distal triceps tendon. This is another patient coming with dorsal wrist pain and swelling, and you can see there's this low signal intensity focus in dorsal aspect of the radiocarpal joint. You can see this is post-contrast images showing some inflammation and enhancement. Oh, actually, this is post-contrast. Some inflammation and enhancement with the epicenter being this low signal intensity focus. These are coronal and sagittal. Again, extensive inflammation around this focus. And all you need to do is correlate radiographically to see the associated hydroxyapatite deposition. All right, with that, I hope that I reviewed the joint pathologies for you, including the inflammatory arthropathies, crystal-induced arthropathies, and some miscellaneous joint pathologies such as PVNS and osteochondromatosis. And if you have any questions or if you have interesting cases, feel free to email me. Thank you for your attention.
Hey, thank you, Dr. Torabi. That was really interesting and very informative lecture. And thanks very much for your efforts. For all of you who attended, if you have any questions, please type them in the chat box, regardless how basic you think or more complex. Just type them in there. So I'm gonna kick off with the question to Dr. Torabi. A lot of nations, such as Mongolia, we don't have dual energy city. Can you explain the principle of dual energy city in goats? Specifically, what you're looking for on images that come across on dual energy city, and why do you use dual energy city, not the normal city?
So, actually, I'm not the dual energy CT expert in my section, but one of my colleagues, Dr. Kiani, who does it, is that they perform the dual energy CT. Then we have to go on another basically post-processing format. And on that, any crystals that basically you choose the gout, and any crystals which has the density of gout, or any artifact, unfortunately, that has density of gout will turn green. And without you doing anything, you just open up that software and it gives you a volume of gout burden. And then what we do is we go through axial images and coronal and sagittal one by one, and we delete any artifact. So if there's any artifact associated with a nail or anything that we suspect is not real gout crystal, we kind of exclude it. So at the end, basically, the software gives you a number that is the volume of gout burden in that foot, and then they use it for treatment follow-up. So if they treat the patient and then they do follow-up CT, it's kind of a more used for quantitative reasons to see if the burden went down. It's not usually, rarely is done for diagnosis. Oh, this patient has foot pain, is it gout or not? Usually the cases we do, they do have gout. They want to quantify the amount of crystal because it gives you a volumetric measurement of whatever turns green as gout crystal, and they can follow that up with treatment.
Great, thank you. Thank you for that. Okay, there is one comment from Taria Wing. It says, thank you so much for the excellent lecture and very beautiful images. So don't hesitate to ask if you have any questions. This is your opportunity. And if you have, you can ask any general musculoskeletal questions. This is your opportunity too. I also have question on regarding ankylosing spondylitis. Maybe is the use of contrast material necessary for imaging in cases of ankylosing spondylitis?
Actually, there's a paper out there on radiographics that they looked at the sacroiliitis and they found contrast to be more sensitive than isolated T1 and T2 weighted images. And I have found personally, sometimes our clinicians order contrast by mistake. We don't know, but it is usually helpful, like in that case of writers with enthesitis, especially because you have, for example, in older population, you do have tendinosis and changes around the tendons, but when you have inflammation, that contrast really brings it out and helps you diagnose. So for subtle cases, I personally find it useful. And there's literature out there supporting for sacroiliitis, contrast enhanced MRI is more sensitive than no contrast.
Okay, thank you. Thank you, Professor. Okay, do we have any further questions? Or do we enter the quiz question session, JP?
Yeah. Thank you.
Okay.
Dr. Rabi, thank you so much for such a wonderful, well illustrated. I mean, those MR images are amazing, especially you compare the CT, MR, and the graphical images. Very educative. It feels like I need to probably leave my cardiothoracic and come to MSK right now.
Oh, that would be wonderful. It was my pleasure. Thank you so much for having me.
Yeah, I think
Yes,
there
thank
was
you very
just
much.
one question. Oh no, yeah, there was a greeting from Indonesia. I said they said thank you for the great lecture. But yeah, so I guess uh, we should be moving to the quiz question now. And thank you so much, Dr. Buriat, for taking time and moderating this session. Really appreciate you.
Yes, it's
And
my pleasure. Thank you.
thank you. Thank you once again, Dr. Tarabi, for the great lecture.
Thank you so much again for having me. Have a good day.
Thank you. All right. So IT team, can we please go to the quiz question now? That time of the presentation where people would be wanting to answer after such a wonderful lecture. The questions which I have is like really simple. After this great lecture, you guys should be having a easy time to answer these questions. IT team, can I get the question, please? I did not see. Okay, let me see if I can share the questions. But do we have a QR code for the answer? IT team, can we get the Oh, perfect. All right, there we go. Okay, so the quiz question. So look at the radiographs there, radiographs of the hand. And what is the diagnosis? So you have 2 minutes, guys. 2 minutes starts now to answer this question. What is the diagnosis? Is it option A is psoriatic arthritis? Option B is rheumatoid arthritis. Option C is erosive arthritis. And option D is reactive arthritis. So please use the QR code, which you can see on the screen, to answer the question. Please do not type your answers in the chat box or the Q&A box. Just pick up your phone, scan the QR code, and you get the options there. Please answer that. What is the diagnosis on this hand radiograph? You guys have 90 seconds more. What is the diagnosis? Is it psoriatic arthritis, rheumatoid arthritis, erosive arthritis, or reactive arthritis? This last, you guys have a last 30 seconds. All right, perfect. So let's go to the answers. So the answer is psoriatic arthritis. It's option A. Here in this radiographs, you see multiple pencil and cup deformities, which is classic of psoriatic arthritis. Also, you see the joint subluxations and the sausage-shaped fingers, which is in keeping with advanced psoriatic arthritis. All right, great. So we go to the next slides, and can we get the QR code for the, oh, perfect, evaluation form? That's great. So again, thanks for all the answers, and that would be the monthly prize for July. And we'll pick the lucky one at the end of this month. And this is the evaluation form. Please use the QR code to use to fill up this evaluation form. And the certificates will be issued only who completes the evaluation. So please fill out the evaluation form using the QR code. It should take you less than 5 minutes to do that. And also, please remember the next session, again, it's an MSK session on imaging of spinal injuries, and that would be by Dr. Robert Lopez from, he is the senior radiologist, MSK specialist from Charlotte, Atrium Health Charlotte. So please make sure to save that date on 4th of August on Sunday at same time, imaging of spinal injuries. All right. So again, once again, I'd like to thank you, all the attendees, for joining for such a wonderful session. Thank you so much, Dr. Buriad, for moderating this session. Thank you so much, Dr. Torabi, for excellent lecture. And thanks all the panelists and the IT team who's made this session very successful. Thank you so much.
Okay, thank you.
Thanks, Dr. Buriad. Hopefully we'll meet sometime soon, probably at RSNA or somewhere.
Yes, we hope. Yes.
Thank you. Thanks, Dita. Thanks. I'll
Thank
talk to you
you.
soon. Terry, nice to see you online. Thank you so much.
Okay, have a good night.
Thank you.
Have a great day.
Bye.
Have a good evening, Dr. Buriat. Have a good evening, dear
Yes,
participants.
thank you. Same to you.